This is a case of a 100-kilogram psych ward patient who is COVID-19 positive. He sustained a traumatic brain injury. The following are the vital signs. Patient was GCS7 and CT scan showed an epidural hematoma at the right temporoparietal area. Patient is assessed using the Lemon abbreviation. Look externally, evaluate the 3:3:2 rule, the Malampati score, obstruction, and neck mobility. Preparation of materials include your monitors, airway, IV fluids, drugs, suction machine, and suction catheter. Since the patient is COVID-19 positive, we will be performing the endotracheal intubation with full PPE. Proper positioning in sniffing position involves approximately 35 degrees of cervical flexion, accomplished by elevating the head using a towel or pillow for 7 to 9 centimeters. Since the patient is obese, ramp position is preferred using a specialized device or folded blankets, which aligns the oral, pharyngeal, and laryngeal axis. Patients may require suction for vomitous secretions and blood in the airway. A few minutes of pre-oxygenation should precede intubation whenever possible. Give the drugs for sedation and muscle relaxation. Due to reduction in muscle tone as a result of general anesthesia, maximize airway patency by forward displacement of mandible. If jaw thrust fails to relieve obstruction, oropharyngeal or nasopharyngeal airway may be used. Intubation proceeds once the patient has fasciculated and relaxed. Scissor thumb and the index finger of the gloved right hand touching the right mandibular and maxillary premolars to open the mouth. Hold the laryngoscope using the left hand with the fifth finger close to the hinge and the handle pointing right of the sagittal plane. Introduce the blade along the right margin of the tongue, displacing it towards the left. Advance the blade until the right tonsillar fossa is identified. Medial to the tonsillar fossa, locate the epiglottis. Advance the blade to the midline glossoepiglottic reflection. In lifting the tip of the blade, you should avoid levering the laryngoscope against the maxillary teeth, as this can damage the teeth and gums. You can avoid this problem by keeping the wrist fixed and moving the handle of the laryngoscope in the anterior-inferior direction. Insert the endotracheal tube with a stylet from the right, keeping it from blocking the view of the glottis. Advance the tube until proximal margin of its cuff lies 3 to 4 cm beyond the vocal cords. Inflate the cuff with 10 cc of air, remove stylet, and connect the ET to the bag or breathing circuit. Anchor the ET tube using your plaster and evaluate the placement of tube. Check by auscultation of the lungs for equal breath sounds. After intubation, you noticed upon auscultation that the right lung breath sound was louder than the left. In the case of an accidental endobronchial intubation, we will just deflate the cuff and move forward.